Last topic is Dr. YAG SLT, Dr. Urvish Vashist.
A very good afternoon. I found it really hard to recover from a sleep apnea postprandial. So finally got to reach here. Uh, so I'll be talking about revisiting the classics, how SLT is reinventing glaucoma treatment. How many of us, can I know that how many of us have an access to SLT? Can you raise the hands? So that means it is not that common in our setups at present. So let me share this case. This 60-year-old diabetic hypertensive male, one-eyed with coronary artery disease presented with uh, diminution of vision in the left eye. The right eye anyhow was an absolute eye. His IOP was always uncontrolled on 5 topical medications plus Diamox, and he was intolerant to oral Diamox. So uh, his angles were open. Left eye was zero point 0.7 cup disc ratio, and it was a laser diabetic retinopathy. We decided to go for TRAB, but the patient did not want surgery. So we did a trial of SLT, and to our surprise, IOP came down to mid-teens, and patient is off Diamox after 6 weeks of the treatment. So it is such a case we never expected such a result with SLT in this case. So this is how we'll be moving in our talk, uh, starting from the anatomy, history, mechanism of action, the procedure, the care, literature, cost-benefit analysis, future of the SLT, and finally we'll to conclude. The relevant anatomy is we should know the anatomy of trabecular meshwork. There are 3 types of trabecular meshwork cells: uveal, corneoscleral, and juxtacanaliculaar. And the most of the resistance to aqueous humor occurs at the level of the juxtacanaliculaar meshwork. So the lasers in open angle glaucoma were first used by Weiss and Witter in 1979. That was an argon laser, but it delivers high energy in longer pulses, causing thermal injury to the trabecular meshwork, resulting in scarring and increasing outflow through the trabecular meshwork. However, it causes more inflammation, it requires more precision to do, and it
We
cannot
will
be
probably
repeated.
put more chairs here. No?
So Latina and Park
Dinesh should also
invented
come. Photo is also
SLT95,
there.
but it was only in 2002 that FDA approval of it was obtained. So
Hardly 3 more
it is a
chairs.
Q-switched frequency double dandy YAG laser with a spot size of 400 microns. It causes selective thermolysis, stimulates remodeling of the extracellular matrix, resulting in increased outflow. From 2002 to 2018, SLT could not gain much ground unless the study of light was published in 2019, which rekindled the interest in SLT. This is that study published in Lancet in 2019, which showed that 95% of the eyes treated with the SLT, they achieved a target intraocular pressure even at 3 years. So 74% of the patients after SLT required no drops to maintain intraocular pressures at target. With the emergence of angle-based surgical procedures, surgeons have become more versed in the art of gonioscopy, and hence nowadays there is more acceptance for SLT. This is how SLT works. It triggers it causes selective photothermolysis, resulting in the it triggers the biological response, resulting in release of MMP, interleukin 1 alpha, interleukin 1 beta, and tumor necrosis factor alpha, which and increase macrophage recruitment. They cause cellular proliferation and ultimately resulting in increased conductivity of the Schlemm's canal. So indications of SLT are primary open angle glaucoma ocular hypertension, juvenile glaucoma, pseudoexfoliation glaucoma, steroid-induced glaucoma, normal tension glaucoma, and nowadays even many surgeons are doing SLT in primary angle closures or PSUG, even if the angle has to be open for at least 180 degrees. The contraindications are angle closure, total angle cynical closure, neovascular glaucoma, uveitic glaucoma, angle recession glaucoma, childhood glaucoma, post-angle surgery, for example, after GAT, where all four quadrants are involved, and a corneal scar due to the poor visibility. So there is hardly any preparation required for this. Just need to instill 1 drop of bremonidine and 1 drop of paracaine before the procedure. There is no need to stop blood thinners before the procedure. It just shows the lens, our trap view lens, which we use for SLT, and it very nicely rotates for 360 degrees. So it's very easy to do. And that's our SLT machine, which we can shift between the capsulotomy mode and SLT mode. So we start with the lower power, maybe 0.4 mg, and then slightly increase in 0.1 millijoule power until we start seeing the champagne bubbles. And we have to do it for 360 degrees, and there should be around 25 shots per quadrant. So overall 100 shots. So this is how it looks. When we fire the shot, we can see some bubbles rising up. That's how. They should be a champagne bubbles, very small bubbles. They should not be a soda water bubbles, large bubbles. If we see large bubbles, then we have to reduce the power. So complications, hardly any complication with SLT, maybe very insignificant, maybe a little bit of IOP spike is inflammation, ocular pain, or PAS. Post SLT care, hardly anything required. There is no consensus on it, but we give maybe patient on loteprednolol for say 5 to 7 days. Otherwise, even that is not required. So it again depends on your comfort level. So the elevated pre-treatment IOP is the single most important independent factor which increases the efficacy of treatment. There is no effect of PM pigmentation, type of glaucoma, age, gender on the results. So this is the literature review. When we see the cost analysis, SLT appears to be on a higher edge because it saves money, it is convenient, compliance wise also it is better. So SLT is here to stay, and even now direct SLT is coming up, which takes hardly 2 to 3 seconds to complete, but the results of its trials are still pending. So to conclude, SLT is safe, effective, least invasive technique useful in achieving target IOP and reducing medications in open angle glaucoma, and a must in the armamentarium of any glaucoma practitioner. Thank you so much.
So with this, we come to the end of the session.